Hi everyone, our subject today is Ataxia in Pediatrics. Basics. Ataxia is a disturbance in coordinated movement and balance, usually manifested by unsteady gait, but may affect extremity along range from transient para-infectious to progressive degenerative types. Acquired ataxia is commonly differentiated into acute, recurrent, or chronic. Acute ataxia in children is uncommon. Life-threatening causes of pure ataxia are rare, must be distinguished from normal clumsiness in toddler and weakness or vertigo in older children or adolescents. Common causes include acute cerebellar ataxia, drug ingestion, Guillain-Barré syndrome. Life-threatening causes include CNS infection, tumor, neuroblastoma, hemorrhage or stroke, hydrocephalus, and drug ingestion. History, duration, progression of symptoms, previous similar or related episode, recent illness, weeks to months, associated vertigo or otalgia, recent head, neck, or ear trauma, recent immunization, incidence of ataxia much less than with the active infection, constitutional symptom, fever, vomiting, diarrhea, malaise, access or exposure witnessed or suspected to medication, alcohol or household chemical, lead or mercury, changes in gait, speech, general coordination, change in cognitive function in conjunction with the motor finding may suggest toxic acquired pathology. Change in personality or behavior, recurrent or persistent headache, vomiting, and or diplopia suggest intracranial mass lesion and possible elevated intracranial pressure. Delay or loss of developmental milestone in infant and toddler. Repeated bronchopulmonary infection, Ataxia-telangiectasia. Family history of ataxia, Episodic ataxia. Physical examination, signs of increased intracranial pressure, bulging fontanelle in infant, papilledema, cushion triad, bradycardia, hypertension, and abnormal or irregular respiration. Meningism include knuckle rigidity, Brodzinski and Kernig sign, fever. Neurological exam may be difficult depending on age, cooperation of the child, include general consciousness, cranial nerve function, strength, tone, deep tender reflex, hyper or areflexia, proprioception, noting symmetry with all. Post-infectious acute cerebellar ataxia is truncal and most severe at its onset. Patients with the chronic lesion usually have normal tone and reflex. In infant, check for decreased truncal and or extremity tone, areflexia, decreased deep tendon reflex. Cerebellar examination, detailed cerebellar examination, difficult to impossible in younger children, requires some familiarity with normal developmental milestone. Observe posture and gait for wide base, staggering, zigzag course, short unequal step, inability to sit, stand unsupported, heel to knee, finger to nose, tandem gait, rapid alternating movement, speech, swaying provoked with the eye closure, Romberg sign, may or may not be present depending on the site of the lesion. Lower vermis lesion cause postural tremor not enhanced with the eye closure. Cerebellar exam also. Limb ataxia more marked in upper than lower extremity, complex than simple movement, fast than slow movement, finger to nose, heel to shin, rapid alternating movement. Distal movement are typically more affected than proximal movement. Oculomotor signs such as rebound nystagmus, Opsoclonus, Full physical exam including rash, tics, middle ear disease. How to approach to child with the ataxia after performing history and physical examination. Is it chronic? Perform a brain MRI. If it is abnormal, differential diagnosis, tumor, congenital malformation, cerebellar hemisphere hypoplasia, vermis aplasia, Chiari malformation, Dandy-Walker malformation, basilar impression, Wilson disease, kernicterus. If it is normal or non-specific, differential diagnosis, post-concussion, Ataxia-telangiectasia, Friedreich ataxia, posterior column lesion, other progressive hereditary ataxia. If it is recurrent or episodic, differential diagnosis, migraine with aura, hemiplegic, basilar type, benign paroxysmal vertigo, metabolic disorder, episodic genetic ataxia, and multiple sclerosis. If it is acute, is there recent trauma or abnormal neurological exam, deficit or local finding, or sign or symptom of increased intracranial pressure? If it is yes, perform MRI. If it is abnormal, differential diagnosis, tumor, intracranial hemorrhage, cerebellar abscess, vertebral artery dissection, hydrocephalus, vascular disorder. If it is normal MRI, differential diagnosis, post-concussion syndrome. If there is no trauma or abnormal neurological examination, perform a drug screen. If it is abnormal, this is drug or toxin. If it is normal drug screen. Is there associated otitis media, sinusitis, severe vertigo with or without nystagmus or hearing loss present? If it is yes, this is acute labyrinthinitis. If it is no, is there recent viral illness, normal sensorium, afebrile? If it is yes, consider MRI and LP. This is acute cerebellar ataxia. If it is no, perform lumbar puncture. If it is abnormal, this is meningitis, Miller-Fisher syndrome, which is type of Guillain-Barré, multiple sclerosis, acute cerebellar ataxia. If it is a normal lumbar puncture result, review family history, consider EEG, BAER, differential diagnosis, acute cerebellar ataxia, a neuroblastoma, Opsoclonus myoclonus syndrome, Brainstem encephalitis, pseudoataxia, epileptic, conversion reaction, hereditary or other neurodegenerative disorder, tic paralysis. Differentiating feature of different structure involving the causation of ataxia. If it is posterior column, speech normal, there is sometime hypotonia, Romberg sign positive, gait, sensory ataxia more prominent on eye closure or in darkness, other sign of peripheral nerve or cord involvement. If it is vestibular ataxia, sometimes there is headache or vomiting, tinnitus, vertigo often present, speech normal. Nystagmus seen in primary position, often with the rotatory component with the direction of the fast phase away from the side of lesion. Positional nystagmus is common. Gait tendency to lurch to one side. Other sign, positional vertigo and blocking feeling in the ear. This is in vestibular. Cerebellar ataxia, sometime headache and vomiting, sometime tinnitus, vertigo. Speech, slurring, scanning, staccato. Titubation, sometime. Hypotonia, often seen in acute lesion. Nystagmus, usually not seen in primary position. Gaze evoke, fast component to the direction of gaze. Rebound nystagmus is also a sign of intrinsic cerebellar lesion. Positional nystagmus is not common. Clumsiness and incoordination of upper limb, common in cerebellar ataxia. Gait, wide base, staggering, lurching, and drunken ataxia. Other sign, dystiadocokinesia, dyssynergia, and dysmetria. Sensory ataxia, The most common cause of sensory ataxia in children is vitamin B12 deficiency. It is more commonly seen in vegetarian. It is clinically characterized by anemia, lethargy, poor performance, cognitive hypotonia, sensory ataxia, and involuntary movement, especially in infant. Neurological examination will reveal hyporeflexia, posterior column involvement, and bilateral extensor plantar response due to additional pyramidal tract involvement. Hyperpigmentation over the knuckles, interphalangeal joint in an ataxic child should suggest the possibility of vitamin B12 deficiency, which is immediately treatable. Top tips. Nystagmus dysarthria in coordination suggests cerebellar ataxia. Hypotonia is usually seen in acute lesion than in chronic. A drug-induced ataxia should always be considered first in acute ataxia. Past history of chickenpox should always be asked. Guillain-Barré syndrome should be considered when there is ataxia with the absent deep tendon reflex. In a febrile ataxic child with history of chronic suppurative otitis media, always rule out cerebellar abscess. Past history of similar episode could suggest the possibility of episodic ataxia. Pellagra-like pigmentation suggests the possibility of Hartnup disease. Increased blood pyruvate and lactate suggest pyruvate dehydrogenase deficiency. Alopecia, dermatitis, and deafness suggest biotinidase deficiency. Acetazolamide is useful for type 1 and type 2 hereditary episodic ataxia. Always rule out atlantoaxial subluxation in ataxic Down child syndrome. Deep tendon reflex can be normal in 25% of patients with the Friedreich ataxia. Most of congenital cerebellar malformation cause non-progressive ataxia. Brisk deep tendon reflexes in a child with non-progressive ataxia suggest the possibility of ataxia from cerebellar palsy. Imaging findings do not correlate with the clinical picture in ataxic cerebellar palsy. Isolated vitamin E deficiency can resemble Friedreich ataxia. Hence, when in doubt, it's always better to give therapeutic trial with vitamin E. Vomiting, nystagmus, truncal ataxia, and torticollis in preschool child suggest the possibility of medulloblastoma. Unilateral cerebellar sign with the feature of increased intracranial pressure in a 5 to 10-year-old child. Think of possibility of cerebellar astrocytoma, which has a good prognosis. Ependymoma of the floor of the fourth ventricle can present with the only intractable vomiting. Suspected congenital disorder of glycosylation in a child with ataxia with the inverted nipple, strangulated pads of fat, and pyrrhody orange skin. Presence of retinal angioma in ataxic child suggests the possibility of von Hippel-Lindau disease. Ataxia with multiple lower cranial nerve palsy, 6th and 7th, suggests the possibility of brainstem glioma, where symptom of intracranial pressure manifest late. Ataxia due to posterior fossa tumor develop gradually but may acutely worsen due to bleeding or rapid development of hydrocephalus. Vertebral artery dissection should be suspected when ataxia develop after neck injury. Vascular disorder, stroke, transient ischemic attack, vasculitis are rare as a cause of ataxia in children. Children with the risk of thromboembolic disease, including Kawasaki, are at higher risk. Ataxia or unsteady gait may be prominent after a head injury due to hemorrhage or cerebellar contusion. It can also accompany concussion. Symptoms of post-concussion syndrome may last 1 to 6 months. Ataxia in affected children may be significant. Imaging at the time of injury is recommended to rule out intracranial hemorrhage. Drug ingestion is one of the most common causes of acute ataxia. Some level of mental status changes frequently accompanies the ataxia in these cases. Anticonvulsant, benzodiazepine, alcohol, and antihistamine are commonly implicated through questioning may be required to identify ingestion histories. Accidental ingestion are most common prior to school age, but peak age again in adolescent with substance abuse. Urine toxicology screen detect a limited number of substance-specific screen for suspected agent should be performed. Ataxia may occur in patients who experience certain subtypes of migraine with aura, basilar, and hemiplegic. Occasionally, these headache manifestations will occur in school-age children. In benign paroxysmal vertigo, toddler and preschool children are affected by brief episodes of sudden imbalance. A true ataxia does not occur, but the vertigo is so severe that the child collapses on the floor and is often frightened to the point that he or she refuses to stand or walk. Nystagmus may be evident, consciousness is not impaired, and headache is absent. Diagnosis is clinical. Specific genetic defect for many metabolic disorders causing episodic or recurrent ataxia are being increasingly identified. In general, the first episode of such disorder resembles an acute ataxia, developmental delay or regression, family history of similar disorder, or consanguinity. Associated symptom of altered mental status, vomiting and diarrhea, unusual body odor, and ultimately a pattern of recurrence associated with illness, dietary change, or other stressor are consistent with these diagnoses. Examples include heart knob disease associated with amino acid, urea, and nicotinamide deficiency causing photosensitivity, maple syrup urine disease. The intermittent form cause recurrent attack of ataxia and encephalopathy during time of stress, and pyruvate dehydrogenase deficiency. Episodic genetic ataxia not associated with metabolic disorder are also being increasingly identified through genetic advance. Ion channel mutation have been identified as a causative in two autosomal dominant episodic ataxia type 1, paroxysmal ataxia and myokymia, and episodic ataxia type 2, acetazolamide responsive ataxia. Multiple sclerosis rarely will present under 6 years of age. Acute ataxia, usually in association with fever, is the most common initial presentation. Definitive diagnosis is usually not made until recurrent attacks have occurred, although imaging may suggest the diagnosis after the initial attack. Ataxia-telangiectasia is an autosomal recessive degenerative ataxia with the associated immunologic abnormality. The ataxia manifests at approximately 2 years of age and progress to an inability to walk by adolescent. Disturbance of voluntary gaze, strabismus, and nystagmus are also common. Telangiectasia develop in mid-childhood, commonly affecting bulbar conjunctiva, nose, ear, and exposed extremity surface. And a diminished immunoglobulin level predispose child to recurrent sinopulmonary infection. Friedreich ataxia is an autosomal recessive disorder characterized by slowly progressive ataxia, dysarthric speech, nystagmus, and skeletal abnormality, flat feet, hammer toes, progressive kyphoscoliosis. Onset usually before age 10 years, significant weakness and sensory loss in distal hand and feet are typical. Cardiac evaluation should be performed to rule out an associated cardiomyopathy. Other progressive hereditary ataxia include sino-cerebellar degeneration, hypo-beta-lipoproteinemia, abeta-lipoproteinemia, ataxia with oculomotor apraxia type 1, juvenile sulfate lipidosis, juvenile GM2 gangliosidosis, Refsum disease, and Marino-Sjogren syndrome. A small number of X-linked disorders featuring ataxia are also recognized. The majority of these conditions will be diagnosed clinically or via specific blood or genetic test. Neuroimaging is usually not contributory. Any of the acute recurrent ataxia, heart-knob disease, maple syrup urine disease, may eventually become progressive without return to the baseline between attack. Labyrinthinitis can complicate acute otitis media, sinusitis, mastocytitis, or bacterial meningitis. Severe vertigo, vomiting, nystagmus, and hearing loss may also be present. Acute cerebellar ataxia, acute post-infectious cerebritis, is the most common acute ataxia in children, approximately 40% of all cases. The etiology is generally post-infectious cerebellar demyelination, which is presumed to be the result of an autoimmune reaction following infection. Immunization has been suspected of inciting this condition, but evidence does not support this theory. A preceding illness, 5 to 21 days, is identified in most cases. Varicella is no longer the most commonly identified infectious trigger due to universal varicella immunization. The onset is acute ataxia and truncal instability with the maximal severity at the onset. Occasionally, a child is unable to walk at all at the onset. Head titubation, bobbing, tremor, dysmetria, and ocular abnormality may also occur, but mental status is always normal and reflexes are preserved. The diagnosis is one of the exclusion. A drug screen is probably the most appropriate test to be done acutely to rule out unsuspected ingestion. Other testing severely primarily to rule out other etiology. As improvement should begin within a few days in acute cerebellar ataxia, imaging should be performed if rapid improvement of ataxia does not occur. If a lumbar puncture is performed, findings are usually normal or may show mild pileocytosis with an increased CSF protein level. Most children will fully recover. Acute disseminated encephalitis, acute post-infectious demyelinating encephalomyelitis, is another post-infectious immune-mediated condition with a more severe presentation than acute cerebellar ataxia, including altered mental status, seizure, which may progress to status epilepticus, and multifocal neurological defect. MRI will show foci of demyelination, and an LP, if performed, will reveal normal finding or may show mild pileocytosis with an increased CSF protein level. Repeated episode may suggest multiple sclerosis. Miller-Fisher syndrome is considered a variant of Guillain-Barré syndrome, although it is also suspected to be a variant of brainstem encephalitis. The cranial nerves are affected by immune-mediated demyelination in this condition. Ataxia, ophthalmoplegia, and areflexia occur after an infectious illness, particularly Campylobacter gastroenteritis. Vertical gaze is characteristically affected, while horizontal gaze is typically preserved. The areflexia aids in distinguishing this from acute post-infectious ataxia. CSF examination results vary based on timing relative to symptom onset. An elevated protein without increased cell count is characteristic later in the course. Ataxia and cranial nerve dysfunction characterized brainstem encephalitis. Mental status changes, hemiparesis, and respiratory irregularities are also occur. Epstein-Barr virus, Listeria, and enterovirus type 71 have been identified as etiology. MRI will show increased signal intensity in the brainstem. Evaluation of CSF show periocytosis, normal glucose level, and normal or slightly elevated protein level. Brainstem auditory evoked response testing indicates abnormality within the brainstem. EEG will be normal. Neuroimaging will yield non-specific finding but will rule out other etiologies. Opsoclonus myoclonus syndrome is characterized by Opsoclonus myoclonus ataxia and encephalopathy. It may occur as a post-infectious entity but is clearly recognized as a paraneoplastic cerebellar syndrome and should prompt an investigation for neuroblastoma or rarely other neoplasm. Acute episodic ataxia, pseudoataxia, may rarely be the only clinical manifestation of non-convulsive seizure activity. EEG is diagnostic. Peers and pitfall. Acute cerebellar ataxia generally has no other symptoms outside of incoordination, unsteady gait, or tremor. Any other finding require investigation of alternate etiology. Miller-Fisher syndrome is characterized by triad of ataxia, areflexia, and ophthalmoplegia, usually diplopia. Failure to recognition and appropriately treat life-threatening causes of ataxia such as elevated intracranial pressure, drug intoxication, intracranial tumor, or hemorrhage, CNS infection.